జర బుడతా ఎక్కడ నడుచుకున్నావు అన్నీ గలీజ్ గలీజ్ అని గలీజ్ దాని మీ ఇంట్లో చెప్తాను గలీజ్ మాట్లాడుతున్నావు
My topic is today's about the examination of the abdomen.
మీ ఇంట్లో
The
చెప్తాను
basic idea of keeping this class as taking Dr. Gauri Shankar sir to reinforce the basics
జిఫ్ లాగా చేసి
of India,
పంపిస్తాను
especially since you're all appearing for the exams.
ఎలా చేస్తా
Sometimes we all have studied in MBBS as sir said, like when we enter into the postgraduate or subsequently after the postgraduation into the clinicals, we don't follow this exact method of examination of the system. At least for the examination's sake, we should know what ideally should be done, what is the right procedures, till finally you see a pass or the certificate actually. So today my topic is about the examination of the abdomen.
Same feeling.
See, abdominal examination or the GI system examination can be a primary involvement of the GI system, or it can be secondary to any other systemic involvement, especially the cardiovascular system or the respiratory system. So what are the general examination findings which have already been discussed in detail by the previous speakers, Dr. Kannan sir and Dr. Gauri Shankar sir? But the basic things with respect to the abdominal system, what we look for in the general examinations, mainly anemia, jaundice, and probably lymphadenopathy, which can be part of the positive findings along with the systemic examination of abdomen, which can result in hepatomegaly, splenomegaly, everything. So other than that, other general examination will be the same as in other systemic examination. Coming to the specific examination of the abdomen, again, it's the basics actually. So I think most of us would be aware, but that's probably according to the latest Hutchinson's clinical examination by 25th edition, there have been slight changes in the examination, how to approach or how to examine a particular organ involvement actually. So generally, it's been divided into 9 quadrants by 2 vertical planes and the 2 horizontal planes, which you are all aware. And what are the vertical planes? The vertical planes pass from the femoral artery below to cross the costal margin close to the tip of the 9th costal cartilage. The 2 horizontal planes, namely the upper horizontal plane or the subcostal plane, they pass across the abdomen to connect the lowest points on the costal margin, and the lower horizontal plane pass across the tubercles of the iliac crest respectively. So based on these 2 vertical and 2 horizontal planes, the abdomen has been divided into 9 quadrants, namely the right and left hypochondrium, epigastrium, right and left lumbar region, umbilical region, right and left iliac, and hypoglostium or suprapubic, sometimes called as the 10th quadrant of the extremity. Again, as with other systemic examination, the basic things is, as we follow the routine, is one is inspection, number 2 is palpation, percussion, and auscultation. So coming on to the first initial finding, the inspection, especially in an examination where all of you are asked to examine abdomen, the most important the examination where we neglect is the inspection of the abdomen. If directly we go and touch the abdomen and start examining for the patient's liver enlargement or splenic enlargement, by the time the patient is multiple times or have been examined by the postgraduates or by other people and the child will be in. The first thing is always the inspection of the abdomen, which is very, very important and which gives us a clue as to which particular organ is involved or any other organ, multiple organ involved is present or not. So what is, when we talk about inspection, first thing is always should be the position of the patient actually. So the position of the patient is always very important. The patient should be lying supine with arms loosely at the sides, the legs uncrossed, the head and neck supported by pillows, sufficient for comfort of the child. See, whether the knees needs to be flexed or not, but sometimes generally not necessary unless the patient is very tense or if the abdominal muscles are not relaxed, then we can ask the patient to flex the knees and make the patient comfortable and breathe deeply so that it is easy for the examination. Second most important is the ambience. Make sure the patient is examined in a good light where the room is adequately warm. There should not be very cold action, so the patient feels uncomfortable. In that case, and the patient may not be relaxed and may not be able to elicit the exact findings. And of course, the last is the person who examines the person hands should be very warm. And always, right from day one in the MBBS, we are always saying, whenever you examine the patient, please stand on the right side of the patient is supine position, and stand on the right side of the patient and examine the patient. See, the traditional teaching has been right from MBBS days is when you examine a patient, always we have been told that we need to strip the patient right from the top to the bottom. But nowadays, now respecting the patient's dignity, or if it's an adolescent child, or if it is a female patient, then nowadays not necessary we need to remove the entire clothing, at least expose from the top of up to the sternum and the bottom up to the pubic symphysis. And when you want to examine the external genitalia, so remove the clothing from the external genitalia finally, and then examine, and then again close the external genitalia. So not necessarily from the nipples to the knees you need to expose. It is basically as per the latest guidelines, just expose from the sternum, the upper border and the lower border to the pubic symphysis, keeping in mind the patient's privacy and the dignity. So the clothing should be drawn up to just above zipidum, the sheet folded down to the level of pubic symphysis. Now, what do you do when we, what are the things you should look for when we inspect the abdomen? So first, make the patient relax. Talk to the patient. Tell them that not going to do any harm to the patient. Just talk to the patient, make the patient relax and comfortable, and inspect the patient for at least 30 seconds. So what are the things you inspect in a child, especially with respect to the abdomen? 1, shape. Number 2, skin and surface of the abdomen. Number 3, movements of the abdominal wall. Lastly, the umbilicus. Now, what do you look for in the shape? See whether the abdomen is normal in contour, or it is full, or it is distended, or in case if it is a scaphoid abdomen. So generally, if the fullness of the abdomen, whether it is a generalized fullness or it is a localized distension. Generalized fullness causes, we all know, fat, fluids, flatus, feces, and fetus in case of an adolescent girl. And if it is localized distension, again, whether it is a symmetrical localized distension or it is an asymmetrical localized distension. If it is a symmetrical, for example, in conditions where there is a small bowel obstruction, distal small obstruction, there will be generalized distribution or generalized swelling of the entire abdomen, whereas in asymmetrical distension, whereas a particular organ alone is involved, there is an isolated hepatomegaly, an isolated splenomegaly, that particular area alone will be distant. So that is asymmetrical distension of the abdomen. Now, of course, if the abdomen is scaphoid, especially in child with severe proteinuria malnutrition, or child with severe malignant disease, or in a newborn period, congenital diaphragmatic area, the abdomen is scaphoid in nature. Common conditions like rickets and hypothyroidism, generally we say a protruded abdomen. So that is what is typically soft in consistency, but it is just a protruded abdomen. So this is about the respect to the shape of the abdomen. So when you look at the shape, all these things needs to be kept in mind. Now, examining the skin and surface, what are the next thing that you inspect in the respect to skin and surface? Whether the skin is smooth and shiny, especially in marked abdominal distension, the skin will be smooth and shiny. And if there's any presence of scars or presence of surgical marks or presence of any striae, everything has to be seen. And if there is a presence of a scar, whether it is an old scar or it is a new scar, whether it's a linear scar or a stretched scar, how do you know that? By the appearance of or the color of the scars. Generally, old scars will be white in color, whereas the recently new scars will be either pink or red in color, and it can be linear or stretched scars, especially striae over the abdomen, especially can be seen in children with marked ascites or in children with severe protein energy malnutrition. And finally, look for any prominent superficial veins. So there are 3 areas where we can look for prominent superficial veins. One, where you see the thin veins over the costal margin, which is not of much significance. Next one is the dilated veins, especially in the probably in the obstruction of either the IVC or in obstruction of superior vena, especially seen in the lower half of the abdomen. So whether, again, to differentiate clinically whether it is an IVC obstruction or SVC obstruction, just look for the direction of the flow. Just occlude the veins with an and then just probably massage it. Just look the direction of the blood flow. If it is from below upwards, it is more likely to be an IVC obstruction. From above downwards, it is more likely to be a superior vena cava obstruction. And if it in caput medicine, where there will be prominent distended veins around the umbilicus, especially seen in children with total hypertension. So these are common areas where you look for the prominent suppression veins. Finally, look for the movements of the abdominal wall. Generally, ask the patient to take a deep breath in and out. So there will be, whenever the patient takes a deep inspiration, there will be gentle rise in the abdomen and there will be fall in the abdominal wall during expiration. And the movement should be free and equal on both sides in a normal patient. And look for any visible pulsations and visible peristalsis. So what are the visible peristalsis, especially in pediatric patient? Look for VGP, visible gastric peristalsis, especially in the condition where you find suspect congenital hypertrophic pyloric stenosis. If you're not able to find it, ask the patient to be fed. Then look for visible gastric peristalsis, which can be seen in the left upper quadrant moving towards the right side. So sometimes in cases of severe pyloric stenosis or obstruction or long-standing obstructions, even a mass might be palpable or even the mass might be visible on the left abdomen upper quadrant extending into the lateral side of the midline, especially into the epigastric region. And finally, umbilicus. Umbilicus is normally inverted and flat, and in case of everted, suspect an umbilical hernia. And if it is an umbilical hernia, just check for whether it's automatically spontaneously reduced, or when the patient coughs, it becomes prominent or not, and it is transversely stretched in a condition where with ascites. So these are the normal inspectory findings of the abdomen. And finally, the inspection becomes complete on examination of the genitalia. So once all of the 9 quadrants of the abdomen is inspected, then look for the groin examination and subsequently the genital examination. Sometimes we tend to miss the groin examination, look for any swelling in the groin, especially roll out as an inguinal hernia or any inguinal lymphadenopathy, or very rarely femoral hernia. So look, is there any palpable or the obvious swelling in the cranial orifices, and especially the groin area. And genitalia, look at the normal scrotal rugosity, whether both the testes are descended bilaterally and whether the penis is normal or not. So this inspection is complete with the examination of the genitalia. Now, see, I've already explained in detail about the inspection. This is just a video demonstration. How do we make the patient lie down? I've told them. See, this patient, as I already said, lying in a supine position with the arms stretched by the side and the legs extended. And since it's an young child, I've removed the cloths from the top of him and I've made the child wear only the trousers. But of course, during examination of the genitalia, we need to remove the trousers also and examine genitalia, and again see to it that the patient privacy is respected. The next most important examination of the abdomen following inspection is the palpation of the abdomen. This is the most important examination in the abdomen actually. So again, in palpation, before I go to the videographic depiction, just explain to you the basic things. Patient to be relaxed and ask the patient to breathe quietly. And if at all the patient complains of any abdominal pain, see to it that area is last examined. So do not examine the area where he complains of pain is the first, so that do not make the patient uncomfortable. The most important point is during examination, the examiner's wrist and the forearm should be in the same horizontal plane. So that is the most important point. And the best palpation technique involves molding the relaxed right hand to the abdominal wall. And the best movement of palpation is gentle, but with firm pressure, with the fingers held almost straight, but with slight flexion of the metacarpophalangeal joints. So the wrist and the forearm should be in the same horizontal plane, should not be flexed. And the best molding technique, as I have diagrammatic representation here, palpation technique involves molding the relaxed right hand to the abdominal wall. The best movement of palpation is gentle, but with firm pressure, with the fingers almost held straight, but with slight flexion of the metacarpophalangeal joints. See, as per the latest guidelines, they say start palpating from the left quadrant lightly and repeat for all quadrants followed by deeper palpation. Start from the left quadrant, left kidney, spleen, then probably right kidney, liver, and initially start with light palpation where you can find any superficial abnormalities. Then for deeper palpation, the same maneuver is repeated for deeper palpation. And especially this photographic in child who is very obese or very muscular patients, you can use a two-hand technique so that once you keep your right hand on the abdominal wall, the left hand can be kept over the right hand, so to exert more firm pressure on the abdominal to examine a better find. See, now coming to the specific organ palpation.
And come in the anti-clockwise direction. We have to ask if there is the child is having pain in any of the quadrants.
Finally, look at the external genitalia, especially in male orifices. So this is how we complete with the inspection of the abdomen. Next, we will follow it with the palpation and percussion method.
Palpation should be superficial palpation and deep palpation. Superficial palpation, we have to start from the left inguinal fossa and come in the anti-clockwise direction. We have to ask if there is the child is having pain in any of the quadrants. In case child is having pain in one of the quadrants, that quadrant has to be examined towards the end of the examination. And in coming to the deep palpation, in deep palpation, we have to examine the organs, demonstrating how to palpate liver. For palpating liver, again, child has to be lying in supine position. In case the child's abdomen is very tensed or we are not able to palpate, we can flex the child's both knees and then examine. For this child, I am examining in the supine position. So we have to start examining in the right hypochondriac region. By lateral to the, our fingers should be pointing towards the midline, and hands should be lateral to the rectus muscle. So we have to palpate for the lower border of the liver. And this we have to this maneuver we have to repeat from lateral to medial direction, so that the lower edge of the liver is delineated. And along with the palpation of liver itself, calculate the liver span. We should do percussion of the liver also, which for which we have to start the percussion from the second intercostal space, using both the hands, and the middle finger of the left hand is the pleximeter finger, and middle finger of the right hand is the plexar finger. So we have to start percussing from the second intercostal space to get the dullness of the upper border of the liver. So I'm getting a dullness in the fifth intercostal space, surface marking for the upper border of the liver. And from the surface marking of the upper border of the liver, we have palpated the lower border of the liver. Between these two, we have to measure using a measuring tape to get the liver span.
See, the ideal position of keeping the hands. No, see, basically. See, there are two methods of palpation of liver, which we have been, so far what we have been following is where you place the palm of the hand horizontally, start palpating for the liver from the right lower quadrant and start moving towards the right hypochondrial area. That is the traditional method we have been pursuing. The latest Hutchinson guideline says another method. I'll just tell you both the methods. The traditional method is where you keep the palmar surface of the hands of the right lower quadrant and start moving towards the right hypochondrium. And where you feel the edge of the liver is coming and touching the radial border of the your index fingers, that probably you take it as the lower border of the liver. So that is the one method of palpation. But what the latest method of palpation is, instead of going from the right lower quadrant, directly place both the hands parallelly on the right costal margin, side by side. Okay, just lateral to the rectus muscle. Just palpate both hands slightly, and with the fingers facing towards the ribs. And you start directly over the right hypochondrial area below the costal margin. And you start palpating. So normally, you will hear a resonant note and start palpating and keep coming downwards palpating. So at the point where you will not hear the resonant note, where you not feel the you not feel the point. Sometimes when you if there is an organomegaly, you will feel a firm surface. But where at the point below, keep palpating downwards. The point where you don't feel the surface, that point you take it as the lower border of the liver. So now ask the patient to take a deep breath in. Either that edge of the liver should come and touch your hand, or it should go beneath your hand. So that is the normal palpation method which we start doing nowadays as per the latest guidelines of the Hutchinson. Okay, so one, directly palpate over the right costal margins. But before, basic point what we should remember is, see, for child with hepatomegaly, normally even 2 to 3 centimeter of liver is normally palpable. So whether it is a significant hepatomegaly or not significant hepatomegaly, it depends upon the size of the liver and of course on the liver span. So that is why the liver span is very, very important. So normally even for above the age of years, 2 to 3 centimeters liver is normally palpable. So that doesn't mean the child has got any hepatomegaly. So in order to clinically differentiate whether it is a hepatomegaly or a push down liver, that is why it is demonstrated how to look for the liver span. So as a part of the complete examination of the liver, right? Okay. So these two are the ideal methods of palpation for the liver. So one is the method directly over the costal margin. The other method is horizontal palpation just from the right lower abdomen. Into any lung pathology. In the examination of the liver, what all when we examine the liver, first thing to identify is whether the liver is enlarged or not. Normally, in children, up to 1 to 2 centimeters of liver enlargement we consider it as physiological. It is nothing abnormal, especially above the age of 4 years. But even less than 4 years, even 2 to 3 centimeters of enlarged liver is considered as normal. So if the liver size or if the liver enlargement is more than 2 to 3 centimeters, less than 4 years, or 1 to 2 centimeters above 4 years, then the hepatomegaly is considered as significant. What are the other things when you look for once we identified as hepatomegaly, if there's a confirmation of hepatomegaly, what are the other things that will be looked after?
Once the liver is palpated, we have to comment about the liver in terms of size, shape, consistency, border, surface, any tenderness is present, and pulsatility is present or not. And next is regarding the examination of spleen. Spleen is not normally palpable. For the spleen to be palpable, it should be enlarged 2 to 3 times of the normal. For examination of spleen, we have to place the left hand behind the torso of the patient while patient is lying in the supine position, and we have to palpate with the pulp of the finger of the right hand in the left costal margin. In case of massive splenomegaly, not to miss the massive splenomegaly, we can start the palpation from the right iliac fossa and proceed towards the left costal margin. In case the liver is not, spleen is not palpable to you by this method, we can ask the patient to turn towards right side in the right decubitus position and examine. In the side, இந்த பக்கம் திரும்புவீங்களா? And we can place our left hand behind the torso of the patient and palpate with the pulp of our right palm and in the left costal margin in a dipping manner to palpate for the spleen. To differentiate between a splenic mass and a renal mass, the differences are in a splenic mass will be growing towards the right iliac fossa, and there will be movement associated with respiration, and splenic notch can be palpated in case of splenic mass, and fingers can be insinuated between the left costal margin and the spleen in case of splenic mass.
So having completed the examination of the liver and the spleen actually. No, so next is this clinic examination. In this clinic examination, we always use a two-hand technique. The left hand is generally placed on the lower ribs, actually, on the posterolateral area. Why we keep the hands is to limit the restriction of the ribs movement. Okay, so place your left hand on the lower ribs already, posterolaterally, and then start palpating from the, keep your right hand on the lateral area and start palpating from the lateral to the medial area. So generally, as she said, splenic enlargement should be spleen should be enlarged 2 to 3 times to be clinically palpable. Splenic enlargement generally starts in the superior and posterior direction, but subsequently once it is clinically palpable, then it starts extending downwards towards the right iliac fossa. That is why sometimes either we start from the right iliac fossa or the ideal method of palpation is start from the lateral end of the abdominal wall and start palpating towards the medial end to identify the splenic swelling. In case if the history is suggesting of a splenic swelling and with normal examination, still if you are not able to palpate the spleen, then in that condition, ask the patient to slightly tilt towards the right side of the abdomen. Just apply a firm pressure from the left hand. Now palpate the spleen. You will be able to identify the splenic enlargement. How to clinically differentiate whether it is a splenic enlargement or what are the things, as we said in other liver enlargement. If you suspect a splenic enlargement, look at the size of the splenic enlargement. Always liver and spleen, the size should be measured in centimeters. Please take a scale, then measure it below the left costal margins and set it is 5 centimeters below the right costal margin or 5 centimeters below the left costal margin, whether it's liver or spleen respectively. Okay. And what are the other characteristics of a splenic swelling? Is one, you will be able to clean the splenic notch which is felt in the lower medial border. Unlike in other swellings where you will not be able to feel the splenic notch. So if you are able to feel the splenic swelling, and number 3, it is not bimanually palpable. So differentiate between the splenic swelling and the left hypochondrium and the renal swelling. These 3 points are very, very important. One is splenic notch, number 2 is bimanually palpable, number 3 is the Yeah, insinuation of fingers. You'll be able to insinuate your fingers below the left costal. So these 3 points clinically differentiate whether it is a splenic swelling or a renal swelling. Okay. The next common swelling that we are generally associated is or to rule out is a renal swelling. So how to clinically examine a renal swelling? Generally, kidney is not palpable except in the newborn period where the renal swelling is palpable, that is called as a physiological. So what are the methods of palpating a kidney actually? So kidney palpation is generally by using two hands technique. One hand should be kept, the left hand should always be kept by the, so it should be kept in the left loin area to whether to identify the left kidney enlargement. I'm sorry, I'm just interrupting you. But of course, the actually you are not ideally supposed to turn the patient. The patient should be in a supine position. Sorry for the mistake, but we'll just continue with the audio. Okay. Right? And the right hand should be kept on the left lumbar area. So, if kidney generally is not palpable, only in conditions like where there's an enlargement of kidneys due to any specific conditions like hydronephrosis or tumors, kidney is palpable. So whether to identify whether it is a kidney swelling or it's an any other mass, this bimanual palpation is going to help us to differentiate between other swellings. So generally, when we examine this method where we keep one hand over the left loin area, the other hand over the left lumbar area, and we just put a firm pressure from the left side actually, and you will be able to identify a kidney swelling. That kidney swelling will come and touch the right hand actually. So that indicates that it is a renal swelling actually. Okay. Similarly, if it is a right kidney swelling, now one hand should be kept below the right loin area, the other hand should be kept on the right lumbar area, and similarly, we have to just push it forward so that whether the kidney becomes palpable or not. So this method is called as, it's called as the ballotability of the right kidney. So this ballotability is possible only in cases of a kidney swelling, which helps us to differentiate between kidney swelling and other splenic swelling or any other masses.
During palpation, if we identify any other mass per abdomen, we have to describe it in again in the terms of size, shape, consistency, any tenderness, pulsatility and all. And next examination in the abdomen is if there is ascites.
హలో
సార్ గుడ్ ఈవినింగ్ సార్.
గుడ్ ఈవినింగ్.
నేను సార్ రాజన్ సార్.
చెప్పనా
సార్ కేసులు స్టార్ట్ అవుతున్నాయి సార్.
స్టార్ట్ అవుతున్నాయా? ఓకే, ఒక 10 మినిట్స్లో క్లోజ్ చేస్తాను.
ఓకే సార్, ఓకే సార్.
Recording in progress.
Gallbladder is usually it's a firm, smooth mass, like it will be just palpable below the lateral to the origin of the rectus muscle. So lateral to the origin margin, if a small firm, smooth mass is palpable where both the borders are palpable, then it is likely to be a gallbladder swelling. Very rarely, in cases of probably an acute calculus cholecystitis or any other rare causes choledochosis, gallbladder mass is palpable. So it is generally in the right type of. So, in abdominal examination, liver, spleen, right kidney, left kidney, and gallbladder, and any other intra-abdominal mass palpable is enough. Next is see, what all I have told, I have just made it as a pictorial representation. It is just the, I'm not again, already we explained about it actually. See, whether it's a renal kidney is right kidney or left kidney swelling. In case of right kidney, the right hand is placed horizontally in the right lumbar region, the left hand posted in the right loin, ask the patient to take a deep breath in, press the left hand forward and the right hand backward, upward and inward. In case of left kidney, the right hand is placed anteriorly in the left lumbar region, left hand posteriorly in the left loin. Again, we ask the patient to take a deep breath in, press the left hand forward and the right hand backward and upward. So again, so after completing this palpation of the abdominal organs, finally again palpate the groin area as well as palpate the external genitalia. What will you look for in the palpation of the groin areas? Whether is there any swelling that is palpable, or if the swelling is palpable, whether there is any cross pimples present or not, to differentiate, and again differentiate whether it is an inguinal hernia or a femoral hernia, or is it a hernia or a inguinal lymph nodes. And finally, examination of the genitalia. Look for whether the testis has adequate volume or not, whether both the testis are descended or not, and look for any presence of phimosis. The next important finding is the percussion actually. See, normally percussion node over most of the abdomen is resonant except over the liver, where it is dull in percussion. Liver, the upper and lower borders of the right lobe of liver can be done accurately by percussion, which is already told to differentiate whether it is a organomegaly or a push down liver. To differentiate that, start percussing from the second right intercostal space or whatever space where the node will be resonant and work vertically downwards. The upper border of the liver is at the fifth intercostal space with the dull retinal node which extends down to the lower body. And again, if there's any other organ involvement, the percussion area over that organ, apart from fluids, it will be duller percussion. Finally, I forgot to mention, in palpation, we should also rule out the suprapubic area, the umbilical area, where sometimes chronic retention of urine can cause urinary bladder enlargement that can also cause mass palpable, where you will be able to identify only the upper border of the mass, the lower end of the mass will not be clinically palpable. So now how to see, once we suspect whether it's a gross abdominal distension, there are different causes for gross abdominal distension. One, it can be a fluid or massive ascites, or it can be a massive ovarian cyst or obstruction of the large bowel, distal small bowel, or both actually. So in order to differentiate whether it is due to fluid or whether it is a cystic swelling or whether it is an obstructive pathology, then we have to demonstrate we have to do the shifting dullness.
We have to demonstrate shifting dullness or fluid thrill. For demonstrating shifting dullness, we have to start percussing from the midline with our hands being in the longitudinal direction and the midline. And from the midline, we have to percuss laterally towards the flanks, either of the flanks. In a patient with ascites, at the point where we get dullness, we ask the patient to turn towards the, in this case, as I'm doing on the right side, I'll ask the patient to turn towards the right, his left side, so that the point of dullness, the fluid shift from the point of dullness. Then with the pleximeter finger in the same position, we have to wait for about 30 seconds for the fluid to shift from this area to a dependent position. After 30 seconds, we have to percuss this area again. And now this area is resonant, which means that the fluid has shifted from this position to the dependent area. Next, we're going to demonstrate fluid thrill. For demonstrating fluid thrill, we need an assistant. We have to ask the assistant to keep her palms over the midline so that the impulse is not conducted through the abdominal wall. And the examiner has to keep her left hand over the posterior aspect of the toes of the patient, and we have to flick from the opposite side. In case of fluid thrill, an impulse will be felt on the finger which is kept on the toes of the patient. This is the demonstration of fluid thrill. In case of minimal fluid, we can also demonstrate puddle sign, which will be like difficult to comprehend in a younger child. For an elder child, we can demonstrate puddle sign, in which a child can be asked to stay in knee elbow position, and percussion to be done in the periumbilical region to demonstrate minimal fluid in the abdomen. And in auscultation, we have to auscultate for bowel sounds and for any bruise heard over the abdomen. For auscultation of bowel sounds, we prefer to auscultate in the right side, towards the right side of the umbilicus, below the umbilicus. In this area, we prefer to auscultate. And in normally about 6 bowel sounds are heard per minute. And ideally, we have to expose the child and examine the genitalia. In a male child, we have to examine if both the testes are palpable in the scrotum and look for any phimosis or epispadias or hypospadias. Without examination of hernial orifices and genitalia is very important, without which examination of abdomen is incomplete.
The basic idea of doing shifting the illness is to differentiate whether it is a fluid or it's an cystic swelling or it's an obstruction of the bowel of this small bowel. In cases of only ascites, there will be shifting the illness, whereas in cases of with ovarian cysts, there will be fully null on progression, whereas in case of distal obstruction, it will be fully resonant. And this is again a diagrammatic representation of the fluid prevalent. Okay. See, the basic idea again of to keep the hand in the center of the abdomen is to prevent the any transmission of the waves across the fatty layer of the abdomen. And auscultation, as you already told, look for bowel sounds, whether normal bowel sounds or in cases of is there any intestinal obstruction, there will be increased bowel sounds. And look for vascular bruise and different areas, especially in the upper umbilical border of the umbilicus, for any hydrogen or in different areas, is there any abdominal bruise? And again, as we all say, the groin examination and the genital examination has to be complete, without which the examination of abdomen is complete. Just one more time, please explain the new method of liver palpation and the order of palpation. As per the latest Hutchinson guidelines, the new method of palpation is place both the hands directly over the right subcostal area, parallel to each other, and with the hands, fingers in a straight position, and slight flexion at the metacarpophalangeal joints, and fingers facing towards the ribs. So this is the new position. Okay. So hands on side by side on the right subcostal area. The fingers straight, slight flexion at the metacarpophalangeal joints, and the fingers facing towards the ribs. Okay. So from what point from left costal margins we have to measure splenic enlargement? Is it right if midclavicular line is considered because splenic enlargement is diagnosed? You see, for only liver enlargement, we do a percussion and find out to differentiate whether it is a pushed down liver or it's a real organ enlargement. But for splenic enlargement, we don't always for the upper border of the spleen actually. So it's only the lower border of the spleen because normally it does not have any relationship with the lung actually. Vascular bruise places and conditions. They normally in children we don't come across, but in adults there are different areas where you look for, especially just in the left upper bottom, above the umbilicus, laterally to the above and lateral to the umbilicus, look for the biotic bruise. Sometimes in the epigastric area we look for the bruise can be seen, and sometimes in the left iliac region also can be some bruise, depending on it, but very uncommon in pediatrics. Kidney palpation, you can stand on the left side of the as the picture depends on the examiner.
Always right leg.
Hutchinson, image, Hutchinson have never said like for the first point, the only thing they are reinforced is stand always on the right side. The only thing is when you look at the left kidney palpation, the image they have kept the left hand on the left right hand on the lower body. But it's not been mentioned whether it is acceptable or not.
For safety, because the first thing is passing exam.
Always
stand on the right.
wherever you are, please stand on the right side. Right side up. Why always on right side? Because we need to be right in passing the exam.
Only for fluid, 500.
Sir, for shifting the blood, at least minimum 2 liters of fluid should be there, sir. But puddle sign 150 ml. But we don't do puddle sign in pediatrics actually. So for shifting the blood, minimal 2 liters of fluid. Fluid trail. Left-handed person can stand on left side.
But I'm always right side.
How to differentiate between an intraperitoneal from an extraperitoneal? Probably sir said I think I'll refer to a surgeon.
Examine the child in this quick question. Also, these things not happen. Important that there is a must find no split you have between intraperitoneal and extraperitoneal. Going to do image.
Don't we have to flex the legs before examining abdomen? In the video, the child's legs were straight. Actually, not necessary to we need to flex the legs. If at all the patient's abdominal muscle is very rigid and is not relaxed, then you can flex the knees and then try to divert the patient as much as possible and make him relax and exam. That is not
Flex is real. But it's older and it is like
no, that's what it's method of
Thank you, sir. We've come to the end of the session for today. Thank you all for your patient listening. Next session will be on 11th of May on arterial blood cancer.